morning. I am Dr. Nidhi Gupta from the Department of Pediatric and Preventive Dentistry. Today we will discuss on the topic stainless steel crowns in pediatric dentistry. These are the contents. What is stainless steel crown? Stainless steel crown is a preformed metal crown used for the restoration of severely decayed deciduous teeth. Stainless steel crown are generally used on posterior deciduous teeth but can also be used on front deciduous teeth and permanent molars as well. Who described stainless steel crown was Angel, but it was popularized by Hemphey in 1950. Now, Wright gave the definition in 1976 that stainless steel crowns are defined as prefabricated crown forms that are adapted to individual teeth and cemented with a biocompatible luting agent. What are the indications? First, following pulp therapy, extensive caries lesions with 3 surface caries lesions, then primary teeth with enamel or dentine defect like hyperplastic enamel and melogenesis imperfecta, then fractured teeth, abutment for space maintainers, teeth with extensive wear, where amalgam is likely to fail, like a proximal box, like a class 2 cavity. Hypoplastic teeth cannot be restored with bonded restorations. Then attachment with habit breaking and orthodontic appliances as a preventive restoration, even for children who are undergoing general anesthesia or patient with severe bruxism. For permanent teeth indications, extensive caries lesion, developmental defects, beneficial for restoring the occlusal and reducing sensitivity caused by enamel and dentine dysplasia. Interim restoration of broken or fractured tooth or teeth with require full coverage restoration but is only partially covered. What are the contraindications? Primary molars close to exfoliation. Second, primary molars with more than half the root resorbed. Teeth that exhibit mobility. Teeth which are not restorable. Patient with known nickel allergy. Now we come to the classifications of stainless steel crowns. First, according to trimming, there are untrimmed crowns, pre-trimmed crowns or pre-contoured crowns. Then as per the composition, 18-8 autistic stainless steel crowns, nickel chromium crowns. According to position, crowns for posterior teeth, crowns for anterior teeth. According to the company, Rocky Mountain, Unitech, 3M, New Smile. According to occlusal anatomy, Icon, it has a compact occlusal anatomy. Unitech, it has the best occlusal anatomy. Rocky Mountain occlusal anatomy is small, and Romco is the smallest and the least occlusally curved. Now the composition of stainless steel crown. Nickel 76%, chromium 15%, iron 8%, carbon 0.08%, manganese 0.35%, silicon 0.2%, iron 76%, chromium 17 to 19%, nickel 10 to 13%, and minor elements 4%. The morphology and the shape, they are uncontoured and untrimmed crowns. These uncontoured and untrimmed crowns, they require extensive trimming and contouring. These types are specially indicated for deep carious proximal caries, and they require chest side time for adaptation. For example, Unitech crowns. Then is the pre-trimmed crowns. These are straight, non-contoured and pre-trimmed. The festooning is done by following a line parallel to the gingival crust. They require additional contouring and trimming. For example, 3M or Unitech crowns. Then are the pre-contoured, pre-trimmed crowns. These crowns, they are pre-festooned and pre-contoured. They stimulate the normal appearance of the tooth. They require minimal trimming and contouring. The pre-contoured and the pre-trimmed crowns are most widely used. For example, 3M crowns. These are the crowns which we use nowadays, and they're easy to adapt also. The commercially available crowns are of the company Rocky Mountain, Unitech, 3M, etc. Now coming over to the placement. The placement is we place the separator, which is mandatory to create the space between the two teeth. The size, the smallest crown that covers all the surface is selected. Then we fill the crown, we dry the teeth and fill it with GIC. We seat with finger pressure and ask the child to bite over it. The excessive cement is wiped off. We ask the child to bite on the crown for another 2 to 3 minutes, and then if excessive cement cannot come out by the normal explorer or some, then we do scaling or flossing. These are the armamentariums used: the cutting scissors, second is the crown seater and the remover. Then is the Johnson contouring plier 417, crimping plier number 112, and the burrs which are used for crown cutting are the pear-shaped, tapered fissure, needle-shaped or smoothing burrs. Then we have the small stone burrs which we need for the crown finishing, and then the cementation for luting the cement on a mixing pad or a spatula, plastic spatula. Now the technique. First, evaluation of the preoperative occlusion. The objective is to replicate the existing occlusion after the SS crown placement. Facial midline and the cusp fossa relationship bilaterally must be assessed. Then we do the crown selection. Check the mesodistal size of the crown using a divider or a vernier caliper. There should be light resistance to seating and proper occlusal height. The crown should be somewhat larger than the tooth. The goal is to get the closest crown that completely covers the preparation and establish the proximal contact. Then how do we do the occlusal reduction? We start with the occlusal reduction with a pear-shaped burr of 1.5 mm uniformly along the cusp height. Then the proximal reduction is done using a fine tapered fissure burr to break the contact. We hold the burr at an angle of 2 to 5 degree to the long axis of the tooth surface, out the buccal and the lingual line angles. Then crown adaptation, festooning the proximal surface before trying the crown to facilitate in case ease of placement. Gingival margin of the trimmed crown should correspond to the gingival margin of the tooth. Then the contouring is done. This is for the better retention, and we use Johnson plier 114 for the contouring, also known as the contouring plier. Then the crimping of the crown. This is very important to the gingival health of the supporting tissue, as a poorly adapted crown will serve as a collection point for bacteria, contributing to recurrent caries or incipient periodontal diseases. Using the crimping plier, the crown is crimped in the gingival third. This procedure of crimping is that the plier must be worked through the entire crown continuously without lifting. So, in short, the conventional technique is checking the fit, finishing the crown, cementing the crown. Now, there are some modifications, like we first come to the Hall's technique. Hall's technique, it is based on the biological or minimal cutting approach, which was given by Dr. Morna Horn, who was a general dental practitioner from Scotland. What are the advantages of Hall's technique? Quick and non-invasive, no tooth preparation is needed, no need for caries removal, no need for local anesthesia and rubber band, and adaptability to the dentist, parents and child. Disadvantages: untreated crowns may cause pulp pathology, difficulty in retainment, and it is supplement to conventional technique but not a substitute. Other indications, it can be used in class 1 cavity, which are non-cavitated lesions where the child is unable to accept fissure sealants. Class 1 cavities where are cavitated lesions where the child is able to accept caries removal or conventional restorations. And class 2 cavities whether cavitated or non-cavitated. Other contraindication, sign and symptoms or irreversible pulpitis, chronic or clinical or radiographic signs of pulpal exposure, unrestorative crowns, or patient at risk for bacterial endocarditis. Now the other modifications, first is the adjustment. How do we adjust the SS crowns? According to MASH in 1981, additional reduction of the adjacent proximal surface of the teeth when adjacent teeth are to be restored with SS crown simultaneously. One at a time to avoid encroachment of space for either one of them. Hoe plier 110 is used for flattening the contact to adjacent proximal contour of the SS crown. Posterior most crown is cemented first and final check for proper border contact between crowns is done. Then extension, adjustment of SS crown with arch length loss or a space loss. Extensive and long-standing carious lesions, there is a tendency for the the teeth distal to it to shift into the interproximal contact area, or because of which there is an arch length loss. The crown preparation are reduced and further, and contact of the crowns are flattened using a hoe plier. The crown can be rotated mesiobuccally as said by M.S. Dougal, or flattening of the proximal contour as said by Mash in 1981. If there is an open contact, we can use ball and socket, that is plier number 112, and create a belling effect. The other modifications is given by Nash in 1981 when SS and amalgam restoration are planned in a single appointment. Then the SS crown is done first, followed by the amalgam restoration. Why? The SS crown, it is a guide in reciprocating the anatomy and morphology of the amalgam restoration. Then the if contralateral first primary molar, as said by Evro in 1977, that primary maxillary first molar crown can be used to restore the morphology altered primary mandibular first molar of the opposite quadrant. Then the modification if the crown size is oversized crown. A large crown can be altered by cutting the edge, overlapping and welding them to reduce the crown circumference to fit a smaller tooth. It was given by Mink and Hill in 1971. In this, first we pry the crown on the tooth. We cut the crown from the gingiva to the occlusal surface, either buccally or lingually as it is shown in the figure. Then pinch the crown together in effect to reduce the crown size. Crown trying is done. Gingival margins of the crown to adapt with gingival margins of the teeth. The edges are cut, repositioned and spot welded, polished and soldered areas. Then modification of undersized crown. A smaller crown altered by cutting the edge and welding an additional piece of band material to increase the crown's circumference to fit a larger tooth. This was also given by Mink and Hill in 1971. We cut a V-shaped groove in the crown on the buccal and the lingual side and try to fit the crown. Spot welding of the strip crown. The spot welding of the strip of the orthodontic band material is placed over the V-shaped groove and retried the crown. Then we solder it, we adapt, contour and crimp the crown. Then the crown extension for deep proximal lesions or subgingival caries. According to Mink and Hill in 1971, again, we prepare the crown, cut a piece of orthodontic band confined to the lesion, spot weld the piece to the crown and check the adaptation and extent, solder and polish the area, trim the excess of the contour of the crown in number 114 plier, polish with wheel before cementation. Then if you need to use crown as an abutment as a space maintainer. Stainless steel crowns used as an abutment to space maintainers, as we can see the crown and loop space maintainer, distal shoe space maintainer. Then there are stainless steel crowns which are used for anterior teeth. According to AAPD, full coronal restoration may be indicated when first caries is present on multiple surface, the incisal edge is involved, there is extensive cervical decalcification, pulpal therapy is indicated, caries may be minor but oral hygiene is very poor, the child's behavior makes moisture control very difficult. These interior stainless steel crowns, they are manufactured by 3M, then is the 3M company and the Rocky Mountain company. In this figure, you can see how the cutting of the interior tooth is done. First, we do it on the cast and then we try to adapt it and then we send. In this, we can have the interior facet crowns also, in which we cut the buccal surface of the stainless steel crown and we place the veneer or the composite over this. This becomes the face stainless steel composite crowns. It completed in single appointment, less time consuming than case restoration, no lab procedure required, less sensitive to moisture, less prone to fracture, longevity, durable as compared to the multi-surface restoration, cost effective, premature contact as well tolerated by the child, and patient comfort. These are the advantages. What are the disadvantages? Significant amount of tooth structure is removed, unesthetic, poor marginal adaptation may cause gingivitis, gingival inflammation due to excessive removed cement, or overhanging distal margin may cause impaction of the permanent first molar. So I conclude by saying that stainless steel crowns are an excellent option for restoring primary and young permanent teeth and are to be considered whenever possible, since their advantage over conventional restoration is proven without harm. Conventional approach of crown placement is better option for pediatric dentists, where an Hall's technique can be appropriate for general dental practitioner or by a pediatric dentist in case of special circumstances. Since cement restoration is very critical, GIC is preferred over zinc phosphate luting cement because it is an adhesive and an antidocarcinogenic